Welcome to This Week in South Carolina. I'm Gavin Jackson. This week we're discussing healthcare in South Carolina, and I'm joined by two heavyweights, Dr. David Cole, president of the Medical University of South Carolina, and Dr. Patrick Cawley, CEO of MUSC Health. Thank you all for both being here.
Great to be here.
Dr. Cole, I want to talk with you first about just how South Carolina is doing. We just got through the respiratory virus season. It's still lingering a little bit too. But tell us about how we're doing with both that and the recovery from COVID, but also how we're doing as a state when it comes to health outcomes.
Sure. Just looking back at COVID and 3 years that maybe I sort of deleted in my mind.
Definitely.
But I would say generically as a state, I think that we did above average, which is not a minor statement. I think we did better than a lot of communities. I know MUSC was engaged across every dimension of the state in terms of testing and vaccines, but I just think that we came together well. I've actually been very proud of MUSC, but also proud of us as a state in terms of what we've done. COVID is now really more of an endemic. Think the flu season. Doesn't mean you should ignore it. Yes, people can get ill, but if we do have the tools and the knowledge and maybe the track record behind us as a society to better deal with that. So this year's, there's a lot. I was telling somebody earlier, there's a lot floating around.
Yeah.
There's just a lot. And the latest respiratory viruses and so forth. But those are, I would say, norms for the season. And Pat, you might comment on this. I don't think that there's something that caused us to start throwing up alarms. In fact, we several years ago said we just need to move forward. We need to be smart. We need to have the capability to deal with things. Always be prepared. But I think it's where we've been.
Yeah, Dr. Cawley, jump in on that.
It's been a little bit of a tough season. These things come and go, so you just got to be prepared when they come. And we did see a big peak, and there is that trifecta of flu, COVID, and RSV now. This year it was flu. I mean, you heard people have RSV and people had COVID, but it was really flu that came in hard. It filled up the hospitals, filled up the urgent cares, the emergency rooms. All the hospitals across the state were experiencing that. The good thing is that the latest numbers I've seen just in the last week, it's significantly better just in the last week. It's just remarkable how you could peak and within 2 to 3 weeks, you're seeing a fourth of what you saw just a few weeks ago.
And we'll be coughing up and through the spring, basically. But Dr. Cawley, when you look at that, are your folks better prepared? I mean, obviously, ever since COVID, we've learned so much. We saw a lot of things exposed, but are folks more prepared to handle these rough seasons?
The flu season, I think we've always been prepared for. And in fact, at MUSC, it's been almost 15 years now that we've actually required the influenza vaccine for all of our people. And we do that to protect ourselves so people don't miss work and can be there, but also to protect the patient. So for influenza season, I think we're prepared. What COVID did, it came in at different points of the year. I mean, we're all used to influenza season being, end of December, going through maybe March. But then COVID came in at different points of the year, and then you got to have that heightened awareness all the time. And I think we're definitely better prepared. What's not clear yet is if COVID is going to stick to the typical respiratory season, that December to March timeframe, or is it going to start popping up at other points of the year? As Dr. Cole mentioned, it is endemic now. We're going to see it. It's not going away. And we'll just have to see how it patterns out.
Yeah, and the COVID pandemic, I mean, it really did affect so many industries, but, medical providers were right there on the front lines too. I mean, you guys were up close. A lot of times didn't have enough equipment, didn't have enough folks. People were getting burnt out. Nurses were leaving, doctors were leaving. What have you all learned from that? Have you recovered from the worst of all that?
We've come out of it, and I think, as Dr. Cole mentioned earlier, I think we've come out of it strong. Not every health system, not every hospital across the United States, I think, is in the same place. I think we were in a good spot before going in. We dealt with a lot. I mean, as you pointed out, we dealt with testing issues, vaccine issues, supply issues, people issues. Most of that we're over. The one that continues to linger are the people issues. And that's not entirely new to healthcare. We've been talking about burnout issues in healthcare for a long time. I keep a standard list of things I worry about, and that's on my standard list, and it has been on my list for 10 years. COVID exacerbated that. It also woke everybody up. We're still dealing with that. It just upended. A lot of people left. We had to replace the people that left. In the meantime, South Carolina is growing and we're seeing more patients, so we needed more people anyway. So we're still working through that, but I think, we got a ways to go. I'm feeling better about it. But I do think we probably have another year or two before we're probably fully
Fully recovered
settled.
from it? Okay.
Yeah, it's fully settled on the people side.
Through a broader lens, and the way I think about this, if you look at the economic impact on the healthcare sector in the United States of America post-COVID, inflation, supply chain, workforce, higher, decreased. It's hit across the United States significantly. The state's done better. MUC's been fine, but I will tell you that a startling fact in the United States of America, the majority of health systems were in the red this past year because of all the above. So it's almost like an economic version of slow COVID, if you think about that. Working through what that looks like has been a challenge. I made an earlier comment that we've done, we've hit above the mark and we're doing well. We are. And we understand and embrace the fact that we serve the state and the citizens of the state of South Carolina. So we stepped forward in that moment. One of the things we're asking for this year and year prior is, hey, let's get some infrastructure for better prediction of the next, so we can be able to better react, respond. One of the things, in my view, if we're talking about COVID as a nation, we were caught short-sheeted. We weren't prepared as well as we could have been, and that's easy to say in retrospect. I'm not throwing stones, but we should learn from those things, right? And how do we as a state have the monitoring ability to say, hey, something's happened in the Far East, this is or is not relevant. We know better what that may or may not do to impact South Carolina. What do we need to do to better be prepared as a community and with all the other health systems, not just about MUCs. We came together to see what we could do. So we're still working through that, but I think our again, I said I'm very proud of, because people have been working so hard and doing great work at MUSC. And we've actually grown remarkably. When COVID hit, we didn't just hunker down and look at our belly button. Yeah. We stepped forward for the state. We actually prepared for the future and have stepped into the future. I don't think many organizations can say that.
Yeah, I mean, I was going to ask you, you're talking about having difficulties within the medical industry itself, but you all have been doing better than others, and you've also been expanding too. I mean, what's been driving those expansion efforts in South Carolina for MUSC?
And I'll give initial thoughts, and Pat can follow. Yeah. I would emphasize strategic growth. If you look at, and you asked earlier about healthcare in South Carolina, and as a prelude to your question about COVID, South Carolina has had, and this is not a surprise, not new, chronic access, chronic healthcare issues in which we're often in the bottom quartile of the nation on any health statistic. So those are challenges that we have to step into. A lot of that is in rural and underserved areas. We're a rural state in general. So part of our growth is the understanding that for us to really make an impact, we have to have a presence with, not for, but with and in partnership with those communities. And right now, with our now 3 additional divisions that never existed 5 years ago, we're in 8 of the most rural and underserved counties in the state of South Carolina. And you say, my gosh, I'm running into a burning house. We have assets and capabilities that can change that dynamic. And it's something that we're very excited about as we lean into the future, making a really positive difference. So we don't sit here 5, 10 years from now, and I'm telling you statistics that have been in place for 20 or 25 years. So we see it as a significant opportunity. If you look at, I think it's important to define what MUSC and what MUSC is not, because I think people get confused. We are the state's only comprehensive academic health system. What's that mean? We have outstanding health care and provide 15 only care in several domains. The only high-end heart in solid organ transplant for pancreas and lung and so forth. All those sort of things are only in Charleston. Those patients, that care, we believe firmly that South Carolina should take care of South Carolinians. That's one. The second thing, when we're in these communities, we feel that best care is local. Nobody wants to travel elsewhere. Nobody wants to travel to Charleston if they don't have to. How do we win, and how does the community win? If we have a presence and partner and we elevate best local care, that community wins, that hospital's better, the confidence in those communities is elevated. And oh, by the way, because of that relationship, we now have access downtown where our best is in terms of quality of complex care. And we can get those patients that need us and have when they need our care. So it's a virtuous cycle, but it doesn't happen by hunkering down in Charleston, South Carolina. You know, we have to have a presence to be able to both deliver on, I would say, our mission and financially to be successful and healthy.
And Dr. Colley, pick up on that too, talk about expanding to these rural areas that were kind of left behind when we saw a lot of hospitals close. Now that pendulum's swinging back around, how are you guys able to get into those areas and to offer that care out there?
I think there's two things that, you know, people focus on the growth of the last 5 years at MUSC, but I think there's two key things. Number one is that culture of education, research, and clinical care that we had. That was us. Add telehealth to that. All right, telehealth started significantly in the state of around 11 years ago when the legislature asked MUSC to develop telehealth services, help develop them around the state. As we started to do that and we started to see what was possible, we then said, you know, we need to step into rural healthcare more. And that was part of what has happened over the last few years. What we find is there's a lot of telehealth we can deliver to those communities, but sometimes it can't all be telehealth. There's things that have to be face-to-face or in person. And we just felt that, you know, we could do it. So our very, very first hospitals that we did acquire were in very rural areas. And then we have learned and developed some things in order to make them thriving. And this is not all in the hospitals that MUSC owns. We have great rural relationships with hospital affiliates. Hampton Regional Medical Center is a tight affiliate with MUSC, and we have a very unique connection there with telehealth, where we provide the backup from Charleston, they provide the on-site advanced practice providers, and that's a system that works really well. So, you know, we don't have all the answers, but I think we have discovered a lot of answers for rural health, and we're confident enough that we feel we just need to step in more. And telehealth was the first. The second thing we're stepping hard into is behavioral health. You know, remember, behavioral health is mental health and addiction. Those are both big problems in the United States. And so we have felt, based heavily on who we are as MUSC, we were doing a lot of telehealth psychiatric care for a long time. And then we took that and we're developing new behavioral health models.
And with broadband and the state getting more connected too, I mean, that's going to be better and better and more expanded across the state too. But when you look at what all this is going to accomplish, I mean, how are you going to measure success? Is it going to be a matter of seeing metrics dropping over the coming years because you've had a better presence in these rural areas, because you've had more telehealth connectivity, or how do you measure success from all this?
Well, we measure broadly. We keep internal scorecards, we keep an eye on matters, and we can see these things improving. We know where this community was, you know, before MUSC entered into partnership with them, and we can see it now. I mean, I just went over that, a lot of details yesterday with the national company around just collecting data here. We know it's better. You know, the next hard part's going to be, can we do that for the entire state? You know, can we get some things going? This cannot be 100% on MUSC. We're willing to go there with our resources to push as much as we can, but you know, hopefully we're going to bring others along with us.
Just if I may, just to follow up, if you talk about rural hospitals specifically, and the dynamic that happens, and I said, you know, MUSC is different because we're a comprehensive academic health system. And say, well, what's that mean? Well, if you look at a rural hospital, the dynamic that happens is inability to recruit and retain physicians and/or providers. That leads to concerns about quality. Patients go elsewhere. That hospital gets in a vicious cycle economically and closes its door. Add overhead in terms of inability to sort of manage the costs of care that continually increase. What we can bring uniquely is we train all of the above. And we have the brand and ability to recruit, so we can start changing the dynamic. Pat already mentioned unique models that we are vetting and testing, which I would say are unique nationally in terms of how do we change the cost of delivering high quality care. So and then we can actually, one of our real prime purposes is to partner and partner productively. It's not all about MUSC, but we can bring in new programs that others couldn't, to help manage, to stabilize, and provide increased quality, increased confidence, and better outcomes. That's just the base when you talk about a rural area. So now we can start doing that. So one metric is that those hospitals are financially stable, and they're not going down. That's going against the national dialogue.
And then Dr. Cole, when you talk about training those folks like you can do at MUSC that you all do so well, and you have this outreach across the state, how do you get folks, first of all, interested into maybe nursing, maybe to becoming a doctor, just any number of these roles in the medical field? And then also, how do you get them to stick around just in South Carolina in general, or even these rural areas? How do you fix that? What's the secret sauce? What's the answer?
Great question. So preface, don't have all the answers, but
Yeah.
I'll give you one man's perspective, and maybe two men's perspective. So if you talk about physicians specifically, but there's a broader topic, and I'm happy to talk on any of these. Most people don't understand that it's not merely a matter of getting your MD. When you graduate from medical school, what do you have? You have an MD and $250,000 worth of debt, but you can't practice because you need to finish your training. It's called graduate medical education, which is residency and fellowship. So one of the things that we're actively engaged in is increasing the pipeline of educational opportunities so that physicians can actually finish their training in South Carolina and therefore practice. An AHEC statistic is that in South Carolina, the best predictor of where a physician will practice is 50-50 if they go to medical school here, greater than 75% if they finish their training in South Carolina. So we're building out programs in these rural areas in critical need domains in which we now have pipelines in which physicians can match, train, learn, and stay. We're very excited about that. If you look at those communities, it requires, again, a unique capability of a comprehensive academic health system that has experience and depth in that field to then partner with those local communities and local hospitals to bring those GME sort of programs. So we've been very focused on that, and we're making we actually had in Florence this past fall, it's hard to express the timeline. We have, in about a year and a half, gone from 0 to accredited. And we'll take in our first class of residents this coming year. And when that's mature in Florence, that'll be 30 primary care physicians being trained, ideally to stay in that community that didn't exist before. And we're just getting started.
Yeah, I worked in Florence for 4 years. I know what they did to invest in that community when it comes to just the city itself, to build it up to create that quality of life, because you are competing with the Charlestons, the Greenvilles, the Columbias of the state to get people to stay there. So it's a matter of scaling up and having that medical industry out there, because you do have McLeod, I know, a competitor in some cases. But Dr. Cawley, how do you see a matter of getting to those folks, so kind of piggybacking on what Dr. Cole said?
Well, Dr. Cole mentioned graduate medical education. And just to play off that for a second, we'll be in Florence, Lancaster, and Orangeburg with new graduate medical education programs in the next few years. I would say the other big thing is two things: nursing and what I call the tech levels, right? So if you look at our workforce needs at MUSC, and I looked at open positions, or if I looked at the number of travelers, half of it's nurses and half of it's these tech levels, right? People are very familiar with the nurse side, but they're not as familiar with the tech level. A tech is a position in hospitals, and it's a generic position, but they're more commonly known as a surgery tech or a radiology tech, a nursing tech, anesthesia tech. There are dozens of these categories, and that's a very good paying job, right? That just frankly needs more people applying to it and getting that education. I say that because most of the tech level positions are trained in our technical colleges, right? We're trying to develop new relationships with the technical colleges in order to get more people trained. They have tremendous depth when it comes to getting to middle schoolers, introducing them to some of these positions. And then we work with them. And we're doing these in a way that it's been a long time since we worked so tightly with the tech schools. That we're offering people, we're paying people to go to school. In the last few years, tuition's been free in the tech schools.
For a lot of
but we've been
high-demand
paying people to go to schools. We'll guarantee jobs when they come out. So that relationship to the tech schools is probably something that's not been talked as much about. And in every community we're in, we're working with the tech school. It's a little different maybe in Charleston versus Florence, but bottom line, it's a collaborative relationship with them.
And you're still competing in a very difficult job environment, right? With the red hot labor market too. So you're really trying to get folks to be interested in the medical field as well. So
Yeah, and people are just not aware of these positions. And they're good paying, stable positions, and they're going to remain stable.
yeah, AI is not coming for y'all yet.
No,
But
no, I don't think AI is going to be an issue. No.
I want to ask you a little bit about trust, right? Because that's been a big issue in a lot of industries and public institutions, including the media. Gallup says 35% of folks have a very or somewhat positive view of healthcare. Americans' ethical ratings of nurses and doctors have dropped over the years from 2019 to 2023, but they still sit pretty high, and they're much better than journalists, so I can't really say anything negatively here. But what's it like, Dr. Cawley, when you hear folks say they don't trust a doctor, or I know there's discussion like you do want to get a second opinion on some things, you do want to advocate for yourself, but folks who come in and say I don't believe what you have to say, or you saw a lot of that during COVID and they didn't believe in the treatments or the practices. What's it like? What's that like on the front lines right now? Are people still that negative towards, I should say, hostile towards doctors?
Well, I would say this is not new. I mean, as the internet has developed and as there's more medical information out there, it's not uncommon for a patient to come in and question a lot of different aspects of what you may be recommending, or you think there's a certain diagnosis. I mean, that's picked up over time. What's different is during COVID, our politics were already divisive. It entered into healthcare as well, and then we sort of became just involved in that. That has significantly decreased. As things have settled back. We've always had to work with patients and help give them advice. We can't mandate these kind of things, but it's just part of what you do each and every day, and it's a partnership to help take care of patients.
My additional comment, and I'm a surgeon. I still take care of patients, still operate weekly. And I've been in this for 30 years, as Pat has. So I see and understand what you're saying, but I would still say at the end of the day, trust is earned. And the relationship you can form with patients, that is still to me an incredible thing, that people give you that trust. Now, I think a positive thing that is happening, which I think is, I mentioned earlier that I think we need to transform healthcare in the United States of America, and certainly we have an opportunity to do that better in South Carolina. We haven't delivered on a lot of things in healthcare. We have delivered on high costs. We've delivered on hyper competition, duplication, and honestly, a lot of things that we know can have in healthcare a difference in patients' lives, we haven't been able to implement. But we can't do it alone. So that's why we turn to partnership as a concept, and a reality. It's like we need to partner with you, either an individual patient or, entities within communities. It's like, so that trust has to be built together.
And a lot of personal responsibility too. I mean, I might not like your diagnosis, but I'm going to have to follow it anyway, or try and better myself and be healthier, because you can't just eat and drink whatever you want and expect things to work out in the end.
It's hard. We talk about delivering health care, but what we really need to transform into is delivering health. It's as simple as that, and it's really complicated. Health means that you need patients and people involved and have ownership of them, right? It's like, it's not dad telling you what to do. It's like, hey, we'll work with you. We'll get to where that is. So that requires partnership.
But we have about a couple of minutes left.
Sure.
I want to ask you a tricky
Sure.
question about abortion, because that is something that has been delegated by the state at this point when it comes to healthcare access. And it's been about 5 months since the state Supreme Court upheld the 6-week abortion ban law in South Carolina. There are exceptions for sexual assault, for fatal fetal anomaly, and for the health and the life of the mother. I want to ask you, Dr. Cawley, what have you all been seeing now 5 months out since that ruling? Has that negatively affected anyone at MUSC to your knowledge?
The hardest part has been, when our obstetricians, gynecologists are faced with a situation that's on the borderline, either because of time or because of the diagnosis, just dealing with that. And, some people are better at dealing with that than others. Some people become immediately fearful. So, I take calls regularly from our frontline physicians who are dealing with some of these things and try to advise them through that. But that's how we feel it. We have had occasional patients who we've had to help through, and they really want it to get to another state, and then we don't abandon them. We try to help them in that. So it's tricky. It's it's mainly at the individual physician level that we're seeing it. But of course, there's patients being affected as well.
But so you do have doctors kind of saying, hey, should I or shouldn't I? Like, do I need to talk to a lawyer, or what do I need to do at this point?
Absolutely. And that's why I'm getting involved as the CEO of the health system. I'm trying to help through that. Our attorneys help through it as well. It's these are not easy cases or easy situations. So sometimes you have to talk it through and find an easier path.
The lens that we look through, the principles, it's patients, and we're responsible for our patients' lives, specifically the mothers. And so it's not just sort of a random sort of thing. Hey, we're, thinking about this. Usually we're in this tight space where there's very real concerns, and we want to follow the law. We're law-abiding citizens and an organization that follows the law. So we are doing that, but trying to make sure that we're, able to support and take care of those we're responsible for.
Gotcha.
That's where it's sort of that balance between those two.
A lot going on there for sure. Dr. David Cole, Dr. Patrick Cawley, thank you for joining me this week.
Thanks for having us.
Appreciate it. Thank you so much.
For South Carolina ETV, I'm Gavin Jackson. Be well, South Carolina.